This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head. I'm your host, Justine Feidelson, here with Dr. Dan Bates. Hey, Dan.
Hey, Juz. How are you?
Good. Nice to see you. Looking forward to this episode.
Yes. All right. Well, we've been talking about it for an hour now, so let's get going.
And our intros are so much more natural. So we're really glad that you're here with us today. And we're, like I said, looking forward to go through a topic that sort of builds on goal setting and, diagnosing and understanding how your pain presents, not only at onset or from a diagnostic perspective, but also when you flare, right? So basically, flare management is a massive aspect of how do you deal with symptoms that are fluctuating, chronic, and persistent, right? And amplified and affected by a lot of the things around you. And the reason it's important and special for Dan and I to be able to have this conversation and why we wanted to have it as a podcast episode itself, rather than just us talking the way we naturally do, as a part of this project and behind the scenes, is that Dan can't really have this conversation the way that we can in traditional settings with his patients. And I can't have this conversation the way that we do with my clinicians or practitioners that I come across, because it either doesn't really apply to what we're trying to address in that window, or it's a limitation of the system, right? There isn't available time sometimes to just dig into this. And it is more personal, right? So that's what we're going to be able to use this episode today, and to really help you see your own patterns and realize that flares aren't random. They don't typically happen for no reason. And very often when I work with patients, that's how the connotation seems, is that it's this thing that happens to you and there is no predating pattern of events. And really, there's a lot of things that happen and that you can predict. And ideally, what we want to come out of this episode is for you to see it faster, catch it earlier and recognize, how do you fall in? And then how do you dig yourself out so that you can do that before you get 5 steps down the line, like we'll go through when we go through what happens with me, because it's an unavoidable part of it. There's nothing wrong with you. You didn't do anything wrong when you do flare, but there are reasons it happened, and there is a way out, and it is very often largely on the patient, because it's those context things that affect it, those stressors that we deal with around our pain.
Yeah. And so, look, I think where the inspiration for this sort of came from is that I was in the UK learning how to do some new stuff 2 or 3 weeks ago. And as part of that, I spent some time at a meeting with a number of other doctors. And one of the doctors was a neurologist speaking about migraines. Now, headaches isn't my strongest area because I'm a sports physician. I do arms, legs, and back. So he was going through essentially the basis of migraine. There's generally 4 phases where you have a prodrome, where you get a bunch of different symptoms that patients will start to recognize if they see it. They then get the actual aura for those people who actually get an aura. Then there's the cycle of pain, and then there's a post-stromal period or a hangover period. And I started to reflect on that and was thinking, you know what, that just sounds like a pain flare. And
it's really familiar.
And the piece that, because, of the relationship Justine and I have, it meant that I was able to go, okay, explain this to me, because I can't sit down with a bunch of patients and go, just take me through each piece of your, of your flare so that I can learn from it, but I can with Juz. So that's what we've done here. And so we sat down, and because Justine had just had quite a significant flare of her pain and had been struggling. And so we've used that to tease it apart into different phases so that we start to recognize, what is happening when it starts. And we're going to share that with you now. So with your last flare, what actually happened? What triggered it off? How did you respond? Where did it end up? And then how did you step out of the flare?
Yeah. So for me, my working hours had increased a lot. That sort of affected my ability to have any self-care and do the things that I normally do to take care of myself, like eat enough, keep in touch with others, right? Go to sleep on time, do the things to manage my nervous system. So I stopped doing all of those things because I put all of my available resources towards my work. That lack of capacity is then what led me to not having the ability to work out, to train, to do movement the way that I normally do it. that increases atrophy, weakness, gets me back in those bad patterns of movement. I have an injury. That's when the emotional component exploded for me. And, I find myself on the ground crying, overwhelmed, scared of how am I going to dig myself out of this hole and this cycle that I got in. And then I'm in the position of needing to reach out. And how do I do that, right? So basically talking through that process with Dan is what allowed us to come up with these 5 phases, right? Of working my way through all of those steps and then trying to dig myself out of the hole and rectify the situation.
All right. So what are the 5 phases? So go for it.
All right. So first phase is trigger or stressor. Second phase is loss of routine. Third phase is worsening pain. Fourth phase is the hole. Fifth phase is digging yourself out.
Okay, so let's go through each one of those phases. So first phase is the trigger or the stressor. So you already identified increasing workload as one of like your personal triggers.
Right.
Run through a couple of other triggers that you or other patients have experienced.
Yeah. So besides workload is a little specific, but even allostatic load in general, which is sort of someone's cumulative stress accruing and eventually tipping over, what they can handle, that can be the stressor, even if it's a little bit more broad. Some other specific ones are overtraining, right? You can physically push yourself into a flare. I did that with doing CrossFit earlier on in my career because I was doing the best I could with what I had.
Good old CrossFit.
Right? Yeah, good old days.
Like I made so much money from CrossFit when it came into Australia. Everyone broke themselves. And
fixing them. I thought I was like, what? You had a secret CrossFit business? I didn't know.
I spent so much. Anyway, that's changed. CrossFit's rounded back a bit when they start. They got a much better strategy to start with.
Yeah.
What's that? Yeah. That must have been, that's 10 years ago now. Anyway.
Yeah. Want to talk about digging yourself out of patterns. Yeah. So overtraining is one, mood is one, right? Increase in depression, increase in anxiety. Even though those are amplifiers, they can be the increased stressor. Loss, grief is a big one. This can be specific things. This can be illness related that you deal with all the time and it's just worse in a particular period. Illness, did you get COVID, right? Did you get some other extra thing that tipped you over? Trauma kind of goes with the mood bucket, but whether that's being around a specific person that's very triggering or sort of reliving and getting stuck in cycles of thinking or behavior that is really revving up your nervous system. Lack of recovery is a huge one I see where for a long time people's sleep gets worse and worse and worse, and then they're in a flare. Well, they're not in a flare by accident, right? They're in a flare because their capacity decreased and they were still piling in the same amount of stressors or load. Along with injury, right? Peripheral sensitizations, increasing specific areas on your body that get a lot more agitated can be that driver. A true injury, or the working, too much, even in not an official work capacity, but maybe other contexts of your life you push yourself in. So family dynamics, personal pieces, travel is a big one. And that's kind of the list I would throw out there.
You've got, like we spoke, you've got, is it 3 Ps? What are your 3 Ps?
People, places, and things. That's a T.
Things.
2 Ps and a T.
And a T.
Yeah, close. People, places, and things. Yeah. What are those buckets for you, right?
So know what your people who trigger you are. Know what the places that
the context, right? The settings.
And know what the things are that trigger you. I think one of the things that I was thinking of as you were speaking there is the sleep piece. And around the sleep piece is simply you just go to bed a bit later. And I think that becomes that lack of discipline when you just go
small.
I just got to go to bed now. Instead, what you do is sit there and go, I'll just watch to the end of this show. It's only another 20 minutes, but that 20 minutes like shifts the whole, means that you go into sleep at 20 past 10, 10:30 instead of at 10 or 9:30 or whatever it is.
Whatever your regular time is. Yeah.
And you just lose that piece of discipline. And as a result, your allostatic load goes up.
Right. Because you have a very small margin for error, right? With chronic illness, chronic pain, you're already kind of close. So that is all it takes very often.
You're already running on the edge.
Yeah.
So,
yep.
All right. So next phase is loss of routine. So what happens? So you've had your trigger. And then just describe, you already mentioned food and exercise, like just describe those in a little bit more detail for what happens.
Yeah. So from a nutrition perspective, especially if you're neurodivergent or you have poor interoception around like awareness of your own appetite, hunger signals, caring much about food, it can be really easy to slip into having less appetite, feeding yourself less. And it's the meal timing and the meal frequency, right? The composition of those meals that will change. Often your aversions kind of tick up. It's like kind of having more side effects and you just, you don't really care about food. That affects your energy. That affects your ability to then move or do any type of significant training. And if you go from working out 2-3 times a week to nothing for a week or two, that's significant. Again, just like sleep, you don't have a big buffer to work with. And because of that, you quickly can develop a capacity issue where your window of tolerance gets smaller. You have less bandwidth because of that lack of self-care. You don't have the support needed for the stress that you were previously tolerating, and you can no longer cope. So that's basically where the lack of self-care creates then an inability to function, and you start to slide back with a lot of the reasons that you were in a lot of pain to begin with. Weakness, inhibition, positional challenges, being sedentary.
And the important part within these is recognizing what your stuff is. So what is your routine, and recognizing when it changes. And so that then becomes, just like having your triple P, or the 2 Ps and a T, the PPT.
We're so good with acronyms.
Yeah, no. You recognize what your people, places, and things are that trigger you. You being aware of your routines and recognizing that you've had a change.
Right.
And that becomes that signal that you're potentially heading into a flare, and that you just need to then start thinking about how you're going to manage that. And it's similar to the same theory as you see with migraines. So you see the prodrome and aura, and then you get the big headache. Well, you really want to look at using your triptans and the medications that turn off migraines when you're in that prodrome and aura phase, so that you don't experience the big headache. And so that's really the way we're looking at it from here. So the next phase is the worsening pain. So it's not just a worsening in the ouchy bit, it's a worsening in multiple things. Do you want to just run through what else outside of the actual, discomfort is happening for people, and what might they see early before they see the increase in pain?
Well, the pain, the primary, underlying condition or what you're dealing with is what is going to increase to begin with. But then the other buckets of central sensitization is what Dan is kind of alluding to, that are going to increase for you as well. So if it's sleep disturbance, that is one that is particularly intrusive for you. If it's how fatigued you get, if it's the brain fog, the desire or the ability to communicate, if it's spasms or cramping or stiffness or certain motor dysfunction things. For a lot of people, it's the buckets of dysautonomia, It's the gut stuff. It's the nausea, the dizziness, the POTS. It's the bladder sensitivity, sensory sensitivities, things like hot, cold, sound, Those type of inputs become a lot more amplified. So this is that phase where it's not only the pain that you're used to dealing with, or an injury on top of it that happened maybe and makes it worse, but all those other presentations and aspects of your pain are also creeping up. So that's where it starts to really then negatively affect that feeling of, can I handle this?
Yeah, and I think that being able to express that to other people where they don't understand that when, the pain's not just the discomfort that's taking place. It is all those other symptoms. All of a sudden, your guts are worse. Every time you stand up,
your
you're
sleep's
getting lightheaded,
disturbed, and all of this then amplifies your pain.
Yeah,
right.
And I think the thing that makes a lot of this so difficult is then the brain fog that goes with it, because people can't express themselves because they can't think their way through it. They can't think about it. They can't speak about it. You can't concentrate, And so as a result, not only is the pain going on, it's difficult to express yourself, what's going on, plus all these other symptoms. So
you don't have the energy to express yourself, really, is also a piece of it, You don't have the bandwidth to communicate what's going on often, even more. And also, it's you feel like people don't want to listen, or what can they do? Can they even help is also a barrier to that.
And I think that once again, as part of, similarly PPT, and then recognizing what's your change in routine, and then starting to recognize what are the things that go off for you. Like, is it that your GIT symptoms go off first? Is it because do you notice you get more sensitive to light first?
Your skin
before
externally.
the pain. So getting to recognize what's happening, so you become cognizant of what changes are occurring so you can intervene early. So,
right.
And so we miss the ability to intervene early and we end up in a hole.
Right. We don't want to get to stage 4.
Your hole was a little bit deep recently. So
it was a deep hole.
Yeah. It was a deep hole.
So
what does that look like, for you and for other people in different ways?
Yeah. Well, that's where grief steps in, right? Loss, hopelessness, helplessness, overwhelm, right? You feel like this is your burden. You feel like nobody can help you. And you get isolated, right? Because by stage 4, it's been hard to communicate for a while, right? You've been already using all your resources on other stuff. And so this is also when you're kind of most vulnerable. And so that's why it's a very difficult, dangerous combination, because it's when it's most important to reach out for help, but it's also when it's most difficult because you have like nothing left to give. That's kind of the stage you're at. And so we'll get into, from a treatment perspective, how we approach these things and what to do by the time you're in that whole situation. But that's why we're having this whole episode, because even I, with all my tools, everything I know, all my experience, I end up in the hole. And one of the things that's really important to realize is like, that's okay. And it's normal, and it's part of the process. And so you can't avoid ever being in that position. What you have to do is develop some skills and strategies to recognize, oh my God, it's happening, right? And then be able to do something about it. Because better a little late than never, but ideally, don't end up like that where you put yourself in a difficult position, because you don't have to.
Look, and I think importantly here, this is where suicidal ideation for many people comes in, because there is the lack of hope for the future. And this is where people being told it's in their head really, you're in a hole already. You've managed to get yourself to somebody that can help, or that you're asking for help, and they indicate it, they tell you something that it's in your head or something. And so where people are at their most vulnerable, that's where those sort of things become, let's be honest, most dangerous. So, but on the other side of that as well, I think that suicidal ideation doesn't mean that people have a plan, but you as an individual need to be able to recognize it and know, well, what's my plan to get out of this? And
I'm in this headspace. Yeah.
Having those, having those places to call. So, once again, in Australia, that's Lifeline. It's 131114. And in the US, the number is 944, or you can text 741-741 or access it via WhatsApp, and that will trigger off that interaction and that support. I suppose we're sort of then talking about what strategies you can use to get out of the hole. So the next step is getting out of the hole. So what happens there?
Well, and real quick too, before we move on to that too, this is the stage that gets labeled catastrophizing, right? Which has like a very negative connotation, but it's not. And again, when you live at a 6 or 7 out of 10, and then you are now in a 9 or 10 out of 10, and there is no easy way to reduce that, that is very scary. And it's validly very scary. And if you've ever been in that position, you could understand that. And so it's not, don't be so, freaked out. It's being able to remind yourself, hey, I've been through this before, maybe, right? Or like, I've gone through stuff like this so many times, and it's reminding yourself of having that 100% success rate from an internal confidence perspective, as well as reaching out, and being able to have someone who is, comfortable and capable to sit in the dark with you. It was so meaningful and helpful for not just the way Dan communicates with me, but for my friend Kathy to be like, I can sit in the dark with you. And until she said that, I, didn't want to reach out because I don't want to burden somebody. I don't want to just put my pain on them. But once someone puts that hand out there, it makes it so much easier to reach back, right? And so I know not everyone has people like that necessarily, but try to develop those friendships and use them, practice using them, because it is hard to ask for help sometimes, even when people love you, even when people care. They do, but on the inside, it can be difficult to, not feel different.
All right, so that breaks it down. So just for clarity, 5 steps of a flare, so 5 phases. So the trigger, stressor. Number 2 is loss of routine. 3rd part is worsening pain. 4th part is the hole. And then the 5th part is digging yourself out. Let's then move into each one of those phases and how do you address them? What are some of the strategies that we can implement once you recognize? And I think that's the point where we're at now.
Yeah.
So you're at the so you know that you're going to a family dinner and whoever is there that triggers you, everyone's got one, will be there. And so you already know. So you're already very cognizant of your triggers. What sort of strategies you're going to implement to manage that stuff?
Well, even first from like a 30,000 foot view, it's the second step is step 5 is along with reaching out is regaining discipline and self-care, right? So it is what Dan is talking about, where then you have to think about what is the stressor, right? So step 1 to being able to reintegrate anything is addressing that stressor, whether it's a workload, right? A boundary issue, different kind of traumas, family dynamics. There's a lot of specific ones that I unfortunately see over and over and over again in these populations, in the trauma bucket. And it's not an accident. So there are aspects that you have to outsource and you have to deal with if you don't want them to keep cropping up, right? This can be sexual trauma, medical trauma, right? CPTSD, family dynamics or history things, your environment, your security. Think like Maslow's lowest level hierarchy of needs. That's what you want to address. Safety, shelter, right? Things that drive that sympathetic response and a lack of feeling safe and secure. So addressing the stressor is the first step to being able to create some capacity and deal with it.
Yeah.
If you travel too much, recover, right? Yeah. It doesn't have to be big dramatic things always. I went on a trip once and I literally felt like I thought I had carbon monoxide poisoning after because my thing broke at the same time. And I felt so awful, like dizzy, weird, just completely abnormal. And it was literally just the result of being so burnt out from travel. I was not poisoned by carbon monoxide. So
good old
allostatic
load. Circadian rhythms. That'll do it for you. So number 1, it's about knowing your people, places and things. And so, if you've got people, have some supports there for you, take somebody else with you, create some boundaries that you will sit within that will protect you maybe from those circumstances. You can probably apply the same sort of principles to places, having somebody with you, having boundaries about where you'll be, how long you'll be there, et cetera, and thinking about those things. And if you do have a psychologist or someone that you're able to talk through those things and have some strategies that you can work through that you go, okay, this is what I'm going to do. And I think that one of the other things is important particularly with workload, and this is the hard one, is saying no, which is really, really hard.
It's a strong suit. Yeah.
Particularly for people like Justine who want to get after it, and saying no doesn't come so well. As part of, you've recognized you have a trigger, that you're going to have a triggering event, or you've had one and you recognize it, what strategies so that we minimize our loss of routine, or you recognize you've gone past that, you've dropped a training program and you've all of a sudden you're in donuts and your carbs are going up.
What protein?
What strategies do you implement to then get your routine back on track?
Yeah. So I love the phrase routine is the antidote to stress. But obviously it's quite simplistic, but there's truth in that. And so like we talked about with other things, what aspect of your self-care can you recognize has gone off the tracks, right? Is it the mindfulness, down-regulating, sort of nervous system management, how aware you are of those things being within what you can tolerate? Is it the way that you're organizing your day, right? From a pacing perspective, is it how you can schedule things that is going to create capacity, right? Are you able to time block stuff? Are you able to take a specific day off? Are you able to reshuffle things in a way that you aren't task switching as much or losing as much energy, right? Even in what it remains of your routine. So you want to address the pieces that are having the most negative effect. Very often this is recovery related, right? The sleep cycle piece of things and fueling. Yes, feeding yourself enough. You can't get back to movement until you have the underlying support from a nutrition and recovery perspective to not have that be an additional toll that creates more flare. So get back to the pieces of routine that you can see have gone backward, essentially.
Yeah, and I think that maybe some of the simple techniques such as, your mindfulness and your breathing, that once you recognize you've dropped your training programs a bit, or you've dropped your walking, or you've changed your diet. Just
You don't do
going,
your wind down
okay,
anymore, like simple, small things.
yeah. So you just go, okay, what I will do is I'm going to step back into my breathing technique. And then,
Right.
just kick that in, and that just becomes where the start
Right.
point is to regain your, the big D word, discipline around, what you do from day to day. And so,
Right.
and this being the prevention strategy from us stepping into the worsening pain. From here, we've now moved into phase 3. So we've
Yep.
got worsening pain. What strategies are you thinking? So we're now starting to really get into a flare. What do you do during this phase?
By this point, ideally, right, you started to reintegrate the things that are more routine, everything around movement related. And so this is the piece where then if it has been from being sedentary, right, from sitting too much, from not maintaining your normal movement, this is where you want to reintegrate what you can, just like with the other things. Think low-hanging fruit, what is doable, right? What doesn't take a ton of energy to start, but has good bang for its buck. So even and above in the lifestyle one, like hydration is a really easy one that people don't realize. And it's such a simple low hanging fruit to get on board before then you start adding more complex things or things that take more effort and energy, like a workout. So start simple and small, right? Start with stability related stuff. Think about what are your problem areas, right? What are your chronic issues? If you've been in this game for a while, is it SI joint instability? Is it hip instability, right? With me, I know, unfortunately, what happened typically, and then what set of interventions or movement related techniques do I need to reintegrate to get myself back on track, right? Is it muscle energy stuff? Like, what do you pull from your PT? What do you pull from your own routine? And then start to slowly build back as you pull the support pieces along: recovery, nutrition, mindfulness, stress management, etc.
Yeah. So from a doctor perspective, what I do with patients, I have a structure where if I have a patient that gets a flare of pain, what I'll do is I will provide them with some scripts that they can get filled out and they sit on the shelf, basically. I commonly use two things. I use an anti-inflammatory with the assumption that they've pushed it too hard and they've got an increasing inflammatory process going on. And I use an anti-neuropathic medication. So most commonly I'll use a thing called celecoxib. I use that because it's probably the safest of our anti-inflammatories when it comes to GIT and cardiovascular issues. It's got other renal and GIT issues to a certain extent, but on the whole, it's probably our best. Anti-inflammatories, it's kind of like they're all kind of evil, just it's the least evil. So
Less evil.
From an anti-neuropathic medication perspective, I commonly use amitriptyline. It's also known as NDEP most places in the world. What we want to do with this is you take that at night, so it helps improve sleep, but it also down-regulates pain. Its mechanism is one where it increases descending inhibition, and which is the outflow of nervous signal that comes down your spinal cord from the brain, and it down regulates pain across the board. Now, interestingly, with patients that are starting to catastrophize more, one of the mechanisms by which catastrophizing increases pain is by a decrease in descending inhibition. So by using these sort of medications, amitriptyline, duloxetine works in a similar fashion. You're directly addressing the mechanism of action by which pain is getting worse with catastrophizing. So if you note that as part of your worsening pain, you start to catastrophize, those sort of medications are the sort of things that you can think about.
Yeah. And remove judgment from that, right? Like, it's not good or bad that you do. It's just then you can identify it and treat it because it's a human response. And so if you can at least be honest about that.
Yeah, so in this setting, I basically will suggest it's 1 to 3 days, get things under control, put everything back on the shelf. Like, it's not we're going to be on this for the next 1 to 3 months. This is a 1 to 3 days, get things under control, put it back on the shelf, get back to what you're doing normally. For those, you can use other medications, or if you're already on other anti-neuropathics, you can manage it if you're not at maximal doses. The other thing that I do for some patients as well is that if we know what flares, and particularly if they have irritable nerve roots and that starts to flare and they can't get on top of them, I'm happy for them to call, speak to my staff, book in, and we do an epidural quickly, get it under control, and then get back to
nip it
life
in the
again.
bud.
So that we're not, so I don't really
ideal.
want patients to be, my pain's worse. I'll book in to see Dan. It's 3 months later before you get to see me. I'll go, yeah, your pain's now worse. Great, let's do an epidural. Like, we don't, like, did that take it away last time? Yes. I go, well, let's do it again. Like, the time is unnecessary. So I will structure it with my admin and nursing staff that we can move patients through quickly. And I think those sort of structures that give patients the options to, here's a medication option, and if we're not getting any, here's an interventional option, and it is short, fast, get on top of it, and then we wind it back. And that's really what I'm trying to do within that, that worsening phase. Yeah. The other thing that I'd like people to do is also not escalate opioids. And so escalation of opioids, unfortunately, the thing that's crappy about opioids, other than they kill you and do all those, take away your motivation and do all that stuff, which is they're all the bad stuff. The thing that I really dislike about them is they cause a thing called opioid-induced hyperalgesia. And effectively what they do is they make the thing that they treat, i.e. pain, worse over time. And the mechanism which they do that is they act on a set of cells called microglia in the spine, which then cause further inflammatory state, and then they heighten nerve activity, and that's how you get opioid-induced hyperalgesia. So I encourage people to, it's not, we don't want to be, you get a flare of pain, the answer is not push your opioids up.
Right. That's why we're doing this episode. Other strategies.
The answer is, let's look at other strategies, of which, mindfulness, breathing.
Which again, are actually affecting hydration. Why you're having the flare, rather than putting a Band-Aid on it.
Yeah. But, opioids is not my choice. And if you can avoid them, please do, because it makes life better for you and everybody else.
Makes Dan happy.
Makes me happier. Okay, so
real quick, Dan, before we move on, I just want to make the point too. The reason it's really important and helpful for Dan to have things to go to and to be able to get patients in relatively fast is because I can speak from personal experience. What adds to the hopelessness and helplessness is you're in 10 out of 10 pain. You know how long it's going to take to build yourself back to get out of that, injury or situation, and you feel like there's no one else that can do anything because it takes 3 months to get in for a block, or there is no strategy like this to quickly see people or to be able to, give them an increase in medications maybe that they're already on. So from how you communicate with your provider perspective, if that's not something that is happening on their end, maybe it's something you can set up, or you try to have this communication where, hey, when I flare or when I get in certain states, how should we handle that, or how could we handle that possibly? And maybe that's something that you're able to bring to the table and communicate through, because that's what creates a lot of the fear when you're in a really vulnerable, high pain position as a patient.
Yeah. And it takes relationship. Help. It takes relationship between you and your clinician. I don't, clearly I don't do that for everybody, but I do it for everybody that I have a relationship that we
trust.
They understand their condition. I understand their condition. We understand what works. And, if things are not going and if things change, that's when we need to take a different angle. It can't be, oh yeah, I'm worse again. Well, are you worse with the same stuff, or are you worse with new stuff? Because if you're worse with new stuff, okay, we need to, that means to sit down and work it out. If it's the old stuff that we can work through quickly, sure, let's work through it quickly. Because, I think we haven't spoken about this part yet, but one of the biggest problems that happens with pain flares is deconditioning, which is what Juz just referred to.
It happens so fast, very fast too.
Yeah, and we want to try and avoid those deconditioning events. And I had a group of patients going through a couple of them recently, and it's really hard. Coming out the other side. I get into that's where training myself and getting back out of my periods of time of deconditioning is annoying, and I don't even have that much pain. So
because I know how much work, effort, energy goes into that, how much time, and to feel like you have lost that is part of the grief. It's not just woe is me, I hurt. It's all the work you have to do to be out of so much hurt. But as long as you have a plan.
So step 4, we're in the hole. What is it in this phase? What is it that you need to do? How do you
this is where
care
for
for
me,
yourself during this phase, because this is generally a very alone phase.
Yeah. This is the extreme sadness phase and the most alone phase for me too. And that's where you have to recognize it and then have strategies really to begin the reach out or thinking about reaching out even in this phase, because it is the need to combat the isolation, right? The increase in grief, loss, fear, the lack of connection, and not having the bandwidth to even communicate it like we talked about. So what are low barrier ways that you can do that, right? You don't always have to talk about the core root, overwhelming, really hard to say issue. You can kind of talk about different things with different people. You can reach out in lower intensity ways to just have some human contact and not necessarily be like, I'm in the dark, will you sit with me? But just get yourself closer to that position. And so this is where, you need to be able to reach out and say, I'm not doing okay. When I have feelings of, I can't do this forever. Like Dan said, it's hard to even say, but it's not, I want to kill myself or I have a plan. It's that I feel like I can't do this forever, which is another way of saying that feeling, right? It's just, I'm not going to execute or act on it, but the feeling is the same. And that's the part where you really got to do something.
Yeah. Look, I think that if you're listening to this from the position of a carer for someone who has chronic pain, this is where you need to be able to have, the I don't know, what's the words I'm like, you just need to be able to go, are you okay? That's where like right. Kathy used the words, I'm happy to sit with you in the dark, which are beautiful words. But just being able to recognize in that person what are their tells that they are.
I have tells. What?
In a hole. Yes. Anyway, I am coming to learn Jaz's tells. She hides them really well. And so let's be honest, I'm in Melbourne, she's in San Diego, we see each other on a screen. So it's not it's not as easy as that. But now that I recognize what's happening for her, I reach out, I just ask. Yeah. And
which I appreciate,
I think that
right?
Yeah. And I think that if you as a carer for somebody can just do the same, because I think that on the carer side, there's a bit of fear as well. There's
it takes
fear
courage.
that can I actually do anything about this? Because most of the time, carers feel they're not in a position to do anything about it. And I think the other thing is, there's fears. They don't want to hear that the person that they're caring for
doesn't want to be here.
Doesn't want to be here. Like, that's pretty distressing.
It's painful.
But it is, the piece is just ask. Are you okay? It is a international thing for a reason, and it's actually pretty solid. And it's probably all you really need to do.
Yeah, and maybe, and that's probably the lesson, from this episode is all it takes is 3 words, really, at the end of the day. And just knowing you have that open line of communication also helps alleviate the overwhelm. And this is my burden and I have to solve this alone. Because Dan's in Australia. What the hell is he going to do to really be able to, help me? But he can help me a lot, because just knowing that you're understood, right? You're seen, you're considered, helps you feel like you're not in this alone, even without Dan having some massive, epic, perfect thing that he said. So you don't have to do anything perfectly as a carer. Just be there. And we'll talk a little bit more on like the stage 5 with the reach out, but that's essentially the stage you want to recognize it at and start to act on.
Yeah. And I say we're there. So we're talking about the reach out, the digging yourself out of a hole. Like, what are the things that once you've gone, I'm in this hole, I really got to get out now. What are the things that you've done and what things can you do to actually get out?
Yeah. So from a larger level outside of, the SOS kind of reach out, I think it's a general ability to start to be able to communicate your boundaries also, like we talked about before, and your abilities and needs around, certain limitations you have, right? So like when Dan and I are working with podcast stuff or the frequency of episodes or how are we doing work, having communication around that is also what kind of helps you start to act on, I'm scared, I'm overwhelmed, I don't know what to do. And beyond the immediate support for that emotional component, you have to start communicating about and strategizing on how you reestablish that routine and the support you need to start to have a schedule basically that works for you, or a routine, or whatever you want to call it. And the piece from a personal perspective is really that although I have tells and, Dan can tell and my friends can tell, people can't tell typically how you're doing, because you kind of, I do in a lot of ways seem the same, externally unless I verbalize it. And so that's where there is an onus on you to say something, because you can't expect people to read your mind. And I'm guilty of this too, where I'm having this very chaotic, really, really sad internal experience. And on the outside, I'm doing my work. I'm doing my thing. I'm showing up for work. I never cancel clients. I don't disappear from social media. That's what I mean. Where like I maintain what I need to maintain externally, but what suffers is the inside, right? What suffers is what you don't see. And that's where there's a lack of congruency, and where Dan, because we work so closely, he sees it, but you gotta say when you need help, because people can't read your mind as much as you wish they could.
I'll give you here's an interesting reflection. So my mum's had chronic pain since late 70s, early 80s, so 4 spinal operations. And so I grew up with a mum that had chronic pain. And so do I know her tells? No, I don't.
That's what I do.
Completely
super stoic.
hid her pain from me so as not to involve me in it. And so I grew up outside of it. Now, I reflect now and I see the consequences of her pain now.
But there was no communication around it.
Can I tell you what her tells are? And I can tell you there's no way that I don't pick them now. Like I'm hopeless with that shit. So there are, as the carer, or let's say the child, you don't see them sometimes. So you do need to reach out and say, hey, I'm not doing so well at the moment. Even if you're, not very good sons, don't pick it. So anyway, sorry, Mum.
Yeah.
I'll try and do better.
Asterisk in here, but from step 1 is just kind of addressing the stressor. This is kind of the piece where it's like, this is why you can't afford sort of long-term, unaddressed, out of your control stressors that accumulate, over time without resolution. Because what you're protecting is very precious and fragile, and no one is coming to pick up the pieces and save you when it all falls apart. And that's where, the resentment, anger, fear, a lot of these emotions, when people don't respect those boundaries, or you feel like they're taken advantage of, or you feel like there isn't communication around that, that's where it comes from as a patient. And that's what we're guarding. And, it's important, and there are ways to. And I think you can, to do that and to be able to practice establishing boundaries takes work. It takes effort. As women, I can speak for myself in particular, overcoming people pleasing took me like 10 years. It took a long time, and it still, kind of is the way that I bend. And so to be able to articulate and express yourself either to people in positions of power, or to develop trust, with the relationships that you have, so that you don't feel scared to speak up for yourself, or like you can't, because that's also a very uncomfortable, incongruent place to be, which also adds stress, right? It doesn't have to be workload. It can be, this doesn't feel right, this isn't right. So it takes courage, but addressing those things is what can help you then free yourself of these loads that you can't, they're not your burden. So that's important.
Yeah. All right. So I think that recognizing that pain flares, they have a cycle. They have, I think,
a set of observable symptoms,
yes.
Boom.
And you need to be able to recognize what are your triggers, what is your changes in routine, what counts as worsening pain for you. So not just it actually
pain.
Hurts more.
Yeah.
What other symptoms are going off, what might go first that you can then recognize when you are in the hole, recognizing you're in the hole, and what that means for you. And then what strategies do you have to dig yourself out once you're there?
Yeah.
Whether that be somebody you can tap to say, hey, I need a hand, whether it can be, hey, you know what, I've got no one to tap, but I'm going to call I'm going to call Lifeline. I'm going to call these people, or I'm going to tap my therapist of some sort.
Or like behaviors. That improve mood too, right, Dan? If you don't have those people, knowing like getting outside, right, listening to music, like there's a lot of things that can help if it's not necessarily a human, maybe, or if that's too hard. Yeah.
So having those strategies up your sleeve to be able to implement once you recognize you're in the hole, and they're the things that we'll leave you with today is probably the main thing. So for me, this was an interesting episode because it came out of a conversation after me recognizing obviously the migraine stuff, but also then having watched Justine go
most recent
through
episode.
her most recent pain flare. And some of the responses to that, with us, and I don't know if you've noticed, we've dropped our frequency of episodes. Well, that's
Dan couldn't hang. I know.
Yeah, I couldn't.
Freaking Dan.
Let's be honest. We were both going at 100%.
No, different reasons, but that's huge. Yes.
Yeah. And I think this episode has been important as it's come from me seeing something like academically to seeing Justine experiencing it, and then for us being able to have a conversation about how we put those two things together, which is not like that's not a common interaction that that you really get to have. So what I hope that everybody is able to take out of this is that if you start to recognize when you are going to have a flare, that there is a pattern, that you know what your triggers are, you can see when you've lost your routine, that there may be something outside just the worsening pain that comes first, whether it be your tummy goes off, or your disorder, or your POTS gets worse, or you get more sensitive to light, your sleep goes off. Like being able to recognize those things early, being able to recognize what your hole is, like when are you at the bottom of your hole?
Yeah, what does that feel like? Right.
What does that feel like? And recognizing that when you're there, you're like, oh, okay, I'm in the hole again.
Yep.
When I'm in the hole, I have to do this. And I think if you can create a if this, then that approach. I am here. What I do to get out of this is I call this person, or I go for this walk, or I listen to this music, or I contact this service, whether it does become a lifeline service that you reach out to. That's the point at which I'm at. That's who I'm going to tap. And then having those strategies to step out of the hole.
Right.
They're important. I want people to be able to sit down and reflect on what happens for them so that they can better manage flares. So, there we go. Jazz, what do you got to say?
There's not a lot I can add to that. That's pretty much it, right? It's how did I fall in? How do I dig myself out? And if you're a patient, thinking about what you do, like short term from an SOS immediate perspective, and then what you kind of need to get back to and integrate long term, those also have patterns to it, right? You'll see, and that gets easier every time too. And, the longer you work on the aspects of the Mars method and the things that help you, support the things that you're living with, you earn capacity, you gain more tolerance over time where you shouldn't be flaring as often or as much or as long, right? The intensity, the duration, those variables change as you over time create more capacity and you bring pain down a bit. And then your stress bucket isn't always this close to bubbling over into flares. But when you have more and more room in there, right, less frequently do those initial stressors tip you up and over, creating like this chain of events. So your flare pattern could and should change too over time as you improve if you work on these things, because it's a result of the underlying habits and the context and the coexisting conditions that are either well managed or at times not well managed, because we're all human and we all do, other things. We have other passions, distractions, whatever it is. No one's perfect all the time. And this gives you a quicker way to recognize it and then do something about it and work that out, just like Dan said, for yourself, so that it becomes easier and less scary, because it doesn't have to be. It's just hard. But hopefully we made it a bit easier and less, daunting from the perspective of feeling like you don't know what to do or you are helpless. So
you're not helpless.
Nope. And right, if you're a physician, think like if the patient has this presentation of a crisis, what do you do? What can you give them? And then what can you help them maybe realize that they could get on top of to help decrease that output? All right.
Excellent. All right, to wrap it up.
Cool. Thanks a lot for listening, guys.
Thanks, everyone.
See you then. Bye-bye.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.